let's talk about the idea of testing, because as sort of I don't know what I describe myself as. I am a hormone specialist. I'm a bone health guru and specialist. In order for me to understand that hormones are doing what I think they're doing, I like to see data and I want to know what's happening in the body. But I get criticized for this because in the space around the guidelines around menopause care, there are the recommendations to not test. So as a specialist, can you kind of give us this background? Like, why is testing discouraged when it comes to menopause hormone care?
I think it's a great question. And it's a hot topic that honestly comes up. If any of us are doing menopause care, it's going to come up several times a day. Like patients are asking for this regularly. Can you check my hormones? Whether it's a phone call, an in office visit, or a patient message. Like people want to know, right? And I think the tricky part is that, especially with our sex hormones, like our estrogen and progesterone type hormones, these levels vary day by day and they vary depending on where we're at in our cycle. So, what might be normal one day might be considered abnormal another. And I think that's really the limitations of where our evidence-based care is right now is that a spot single blood test of hormonal levels is not really giving us that broader picture of what's happening throughout that whole cycle journey. And so it's such limited data and you can check the numbers and you can say, all right, well, they're in a normal range, but that doesn't necessarily tell us that things are communicating well with each other, right? So I think the real limitations in current care is how much can that drive actionable change? Like what is that going to change in terms of how we are going to manage that patient? And based on our kind of like current hormonal testing standards, a spot single blood test really doesn't tell us a whole lot.
Yeah, agreed. And I have days where I realize, man, I kind of wish I didn't have all this data sometimes, you know,
Yeah.
because it sometimes can be challenging. It doesn't make sense. It's not what you expected. Let's start sort of in the post menopause timeframe. So the initiation of HRT, once you have this risk benefit conversation with a patient, are you recommending testing at this point for hormones or for anything else? Because where I struggle with the guidelines is the recommendations is to go symptoms only, and as long as that woman is otherwise healthy, we don't need any additional data points. Is that how you're practicing currently?
Yeah, I mean, with my group and my partners, like we really are following that standard of care that's based on what the evidence currently shows us, right? And that doesn't mean that what we have in terms of evidence is great. It's just where we're at, right? But yeah, so the current standard is treating according to symptoms and staying within a healthy prescription range. There are ranges of these medications that are known to be safe. And so, as long as we are supporting women in that safe, healthy range, adjusting based on current guidelines. And I'm not saying that this is how I 100% feel, but based on the current guidelines, adjusting one's hormones according to a hormonal level, isn't necessarily going to give us the outcome that we want. As a woman, we want to feel better, right? Like we want these symptoms to go away, whether it's hot flashes or night sweats or mood swings, all of these things. We want to help that patient feel better, and that patient wants to feel better. So that's where the current guidelines are guided or targeted. Is that if there's not a certain range that's been specified and known to resolve those symptoms, then let's just actually target those symptoms rather than chasing a number.
Yeah, and this is where as we build out programs at LifeMD, I mean, we're being very considerate of the guidelines, and we will have a pathway that does exactly that. So this is symptom management. We can use hormones to treat symptoms. Those are the guidelines. I think where this gets tricky is when patients start coming in asking, what about, is this cardioprotective? Is this actually potentially helping my brain? And then, where my specialty lies is this helping my bones? From a bone perspective, we do have objective data. We do have data that says you have to reach certain thresholds of estradiol levels in serum to be able to slow down bone loss. Now, those levels are actually much lower than most people think, but there are levels. And then also, if I'm looking at other data points, I can say, okay, well, I'm still not seeing the bones slow down. I'm not seeing the bone turnover markers slow down. And if I increase estradiol levels to another marker, to another threshold, I watch FSH drop, then I see the bone turnover markers drop. So we started creating these protocols around this concept that we can use biomarkers in a different way. Are you doing anything like that in your practice? I know I'm kind of unique in the bone health thing, which is why I push so hard on biomarkers. But how has this developed in your practice, Mary?
Yeah, I love what you're saying. I'm like, this is phenomenal, right? Like, I think when you can see a shift in numbers change, then a downstream shift in other numbers, especially for bone density and bone health, I think that can make a significant impact. Our My current practice as an OB-GYN, we are not following the bone turnover markers and whatnot. I think I might put that more in the bucket of like an endocrinologist type of thing. But I think what you're presenting or proposing here is phenomenal. And if we could create data that supports that, then I think we could see these algorithms of care shift in a broader perspective. I think we would see kind of our standard practice being able to incorporate that. If we could take all of this information that you're finding based on these algorithms, right, and then show an evidence based care model that makes that actionable, I think that would be so profoundly useful.
Yeah, and so this is why I love bone. As I love talking about bone. A lot of women are asking me though about heart health, and unfortunately, the heart doesn't give us a good biomarker. We don't have a blood test that we can follow. We have imaging, but man, it is so delayed. And same thing with the brain, right? No real biomarker to follow, and imaging is really delayed, if it even means anything at all. It's one of the hardest things to track. So then we are sort of in this middle ground, I think, right now with menopause care, where we're treating symptoms. Women have questions, and we don't have great answers, which then brings me to what other data can we acquire? And this is where potential urine tests come in. So, Amy, maybe let's switch back to you. Tell us about how you how you ended up in the world of urine testing for hormones. You mentioned infertility, so maybe start there and kind of work forward in the progression and the development of UVA.
Yeah, sure. So, as I said earlier, like hormone testing, hormones are so critical and core to every experience that we kind of go through, especially as women. When you talk about a menstrual cycle, it's called a cycle for a reason. These hormones are behaving in a somewhat predictable manner that are leading to certain events that allow you to release an egg, hopefully create an embryo, and then if you don't, you have a menses, right? You have a period and you reset everything, which is kind of amazing that our bodies are able to do this. But the signals that are kind of navigating that are these hormones. So the reason that this kind of became important to me, what the concept of monitoring these hormones to help navigate a fertility journey is not novel. Right? We have ovulation tests, we have pregnancy tests. Those are all detecting hormones through urine. The problem, though, is that all those tests that are available from your drugstore are qualitative. So you get a binary yes or no. In some cases, you may get like, oh, it's extra high. So that smiley face may blink versus just be present, right? But when you have irregular cycles, like someone like me, or you have a hormonal imbalance, those signals are just not sufficient. Because what I was finding in my journey is that I was basically seeing a hollow circle most days I was testing. I would see a smiley face only 5 days, which tells me that I'm in my high fertile window, and it never blinked. So it never told me that I was in my peak fertile window, which is when you would want to time intercourse, right? And so when I at like fast forward 2 years after I developed UVA, learned that my hormone levels were just not reaching those thresholds that those tests were designed on. I was still ovulating, I was still releasing an egg, but those tests never indicated it to me because I was just not meeting their thresholds. So what I realized is that women needed that quantitative data because we're not normal. Like the abnormal is the new normal. We're not robots. We don't follow these perfect textbook curves that everyone is striving to hit. It's not reality, right? So how do we embrace that unique and individual manner that our hormones are behaving in, which is absolutely normal for our bodies, but we need to understand that trend so we can react to it. So that was kind of the concept behind building this at-home testing platform that was actually quantitative and gave you levels that were unique to you and learned your personal hormone profile. But the reason that we actually scaled into perimenopause is quite natural as well. We never intended to be just a fertility company. It was a use case that I was navigating myself and seeing it was a much bigger problem than industry kind of wanted to accept. No one talks about it. It's a very personal issue that women and families are navigating. But when you open up that can of worms, there's a lot of people that are dealing with similar stories. And so we could solve that problem. But what we also noticed is that after we launched Duva, 46% of our users were above the age of 35. And many of them were telling us that they were perimenopausal. But why were they being diagnosed with perimenopause? It was because they were a bit older and they were struggling with irregular cycles. But then when you dig a little deeper, they had always had irregular cycles just like me, right? They were just being diagnosed because of their age. And so the thought was, well, there has to be a hormonal signature for women that are navigating perimenopause. Is there a way we can quantify that irregularity? And that's why we kind of scaled into perimenopause. And turns out we were right. There really is a hormonal signature as you're navigating this like decade experience that many women have to go through.
Yeah, amazing. And my own journey in managing hormones and talking about hormones and treating hormones started out really, very much post-menopause, and then has worked its way earlier and earlier as my patient population has gotten younger and younger. And when I started, recognizing the paucity of research that is at perimenopause, I started looking for more tools, and this is where actually you and I, Amy, sort of intersected. But Mary, can you give me your experience now? So if you maybe start with postmenopause care, if does urine testing help you at all in this space, or is it only perimenopause? Give me your current experience.
Yeah, I mean, I think that there's a world for both. I think that urinary testing in menopause can be especially helpful for that before and after. I'm thinking like before you start a medication, like let's say you're having various menopausal symptoms, and you want to kind of assess your baseline levels, and then you start a hormone therapy, for example, and then you check and follow your hormonal trends afterwards. And you also kind of incorporate what your symptoms are at that time. So we can kind of integrate all of that information to help us really find what works best for this individual. Could you do that by a blood test? In menopause, it's a little bit simpler to do a blood test because more consistently, we aren't going to have a lot of variation of our hormones as much day to day as we are in premenopause or perimenopause kind of thing. So you could do that with a blood test, but it's nice when you can just do it from home and you pee on a stick and you can check it every day. And then you can follow these trends over time, right? So it is really cool to see working with UVA, we'll see these graphs of like the pre-hormone to the post-hormone, or even kind of relay that same concept into like you're on a current hormonal dosage and maybe you're still having hot flashes or night sweats or sleep disturbance. And then you adjust your dose and then continue to correlate your hormones. And you can see that as your hormone levels shift, those symptoms should start to potentially drop away. If they don't, and I think this is really where sometimes the important part is too, if they don't, well, what else do we need to look for, right? Like maybe some of these things are based on our estrogen or progesterone levels, but is there a world in which this could be thyroid or other metabolic disorder, right? And so we don't want to assume that everything is strictly perimenopause.
Yeah.
Perimenopause and menopause also integrates with a lot of our other hormonal systems, right?
Yeah, so much, right? And this is where clinically it gets really challenging, especially if you're trying to create something that is, that is relatively narrow, like hormone care. You have to consider the other inputs. I want to double click on something you mentioned around serum testing, blood testing, how this can be done. And one of the challenges I've seen too is that depending on the type of hormone therapy that a woman is on, whether it be a patch, a gel, a cream, and even like compounded, like troches, for example, testing is testing can be difficult, and serum's going to show. In the cases of a troche, is going to show nothing. In the case of a cream, it's variable depending on how it's absorbed and how it's stored in the sub-Q fat, and then patches and gels a little bit different too. So I have found we test and we do use those in conjunction with asking other questions, looking at other biomarkers. But it has been difficult. And I've started using urine testing, quantifiable urine testing like UVA, as an additional tool in this space. What's your bias now that because you're very familiar with this technology, Mary, are you doing more blood testing or more urine testing at home with your patients?
I mean, for me personally, like I said, I'm so much more out of the clinic than I'm in the clinic at this moment. But what I would say is I feel like there's just tremendous space to push forward into having this be an option that's offered. Like if we're talking about that menopause space, I think if you ask 100 patients, you might get a handful of different answers here. But I think a good majority would be like, absolutely, I'd love to follow my trend over time at home and not have to come in for a lab and not have to, waste my time to, schedule that appointment, come in, go home, wait for results. Like I think the urine test is cool not only because it's convenient and done from home, but because it's going to give you pretty instantaneous results. So I would say I like it as a nice offering if we're talking in the menopause specific space. I think it's pretty cool.
And then I have more questions about perimenopause, but actually, Amy, I want to talk to you about, now that you had, or maybe you can tell us how many women are using this tool, this UVA as a tool. But now that you've had at least, thousands of women run through this, what is the experience specifically for post-menopause care? What are you hearing as from a feedback perspective?
It's quite good. So, I mean, we have over 15,000 women that have now circulated through UVA across multiple cycles, and you can just imagine the value of a data set like that, right? Um, to comment that Marion, you were talking about earlier, like blood tests, like UVA is only going to give you a piece of the puzzle. It's not going to give you the full picture, but it can help you narrow down like where do we need to focus or where should we redirect our attention now, right? Which I think is a great lens into treating your patient. It's obviously much better to treat a patient with data than just following a pattern or protocol blindly. And so what I'm seeing for our postmenopausal women is that they're actually using UVA to manage their treatment and their care options. So they'll get on a protocol. Obviously, a lot of our users are actually getting baseline data with UVA before they start testing, similar to what Mary was saying. But then more importantly, once they begin a therapy, like let's be real, no one likes to pee on a stick every day. So how can we make this as effective for you as possible? We're seeing that women are starting to really get insight on how their hormones are behaving and how their symptoms are correlating with that. So when they start to experience, for example, at the highest level, some difficulty sleeping, they'll monitor with UVA, see that their estrogen is lower, and then up their dose of estrogen, especially if it's a topical, it's a little easier to do. Right. And so we're seeing that women are actually being quite responsive to the UVA data. And again, working alongside a clinician to make sure everything is copacetic here. But it is quite useful in that way. And you are getting the real time results, which is also incredibly valuable.
Yeah, and how are you finding that's received by physicians? Are these mostly women who have been referred to you by their doctor, and therefore their doctor is sort of on board with this type of at-home testing, or do you run into friction where someone comes in because it's a direct-to-consumer product? A woman comes in a direct-to-consumer fashion, and then she's trying to tell her doctor, "Hey, I did this data at home. I want to change my dose." What's happening there?
Sure. I mean, it's a little bit, it's a mix of everything, right? And you're going to get mixed feedback on all ends. So most of our users, not most, so like let's say a subset of our users don't have a clinician at all, and they're finding us in a direct to consumer fashion, and then they're actually looking for us to make a referral to a clinician. So we've currently partnered with over 500 clinics. They're all trained in UVA's data, and they have custom protocols and so on, so they can treat these patients. So it's great for both the patient and the clinician in that situation. In other cases, we have those same 500 clinicians that are actually recommending the product to their patients. And that's also a source of friction, right? The patient might not be ready to adopt a technology or make that commitment time wise that I want to test every single day and figure it out. It's not always a clinician point of friction. Could also be on the patient side. And then you do have the flip side where you have a patient that found us, has a clinician already that's not necessarily a partner of ours, takes our data to them. The clinician might be like, hey, this is great. I'm not sure what to do with it. But then honestly, it's a lead gen for us because then clinicians reach out to us saying, like, hey, my patient brought me this report. What does this mean? How do I get on this? And then we end up training the clinician. So I think it's a win-win. What I can say is a common denominator across all those scenarios is that the end result is wanting the patient to feel better. So whatever solution or technology or platform will help them achieve that, everyone is very receptive to incorporating.